We know when I should start saying these
Yep.
things.
We're recording and you can start anytime.
Okay, this is Division 3, and here's the prelude, I guess. As Chair of Division 3 of the House Finance Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic and in accordance with House Rule 67 and the governor's emergency order number 12, pursuant to Executive Order 2020-04, this public body is authorized to meet electronically. This is a public meeting pertaining to division orientation matters. Please note there is no physical location for members of the public to observe and listen contemporaneously to this meeting. However, in accordance with the emergency order, I am confirming that all members of the committee and select legislative staff have the ability to communicate contemporaneously during this meeting through the Zoom electronic meeting platform. And the public has access to contemporaneously listen and, if necessary, participate in this meeting by the Zoom platform or by telephone. All necessary access information has been made available in the House calendar and through the electronic calendar on the General Court website. The notice for this meeting complies with House rules and RSA 91-A. Anyone who has a problem accessing the meeting should email lba_fiscal@leg.state.nh.us. In the event the public is unable to access the meeting will be adjourned and rescheduled. LBA staff are on the meeting assisting us. Please note that all votes that are taken during this meeting shall be done by roll call vote. And as an aside, we don't anticipate any votes being taken. Let's start the meeting by taking a roll call of attendance. When each member states their presence, please also state whether there's anyone in the room with you during this meeting, which is required under the right to know law. Can you handle that, Harry, for me, please?
Sure.
Thank you.
Representative Wallner.
Representative Wallner is present, and I'm in my home in Concord, and I'm alone.
Representative Nordgren.
Representative Nordgren, I'm here in my dining room in Hanover by myself.
Representative Rogers.
I'm Representative Catherine Rogers. I am in my apartment in Concord with my dog Romeo.
Representative Earth.
Present, I'm in home alone in my home office.
Representative Weiler. I guess is missing. Representative Edwards is also missing. And I'm Representative Bean. I'm at my home in Guilford and I'm alone.
Okay, so I'll close this. And who am I starting with?
Good morning, Representative. I can jump
Go
right
ahead.
Oh, Karen.
Hi,
I
sorry,
recognize the voice. I couldn't find the face.
I won't be on camera today. I apologize for that.
No problem.
So if you're ready, we can turn it right over to Deb Sheets. She will share her screen and begin the presentation for long-term supports and services.
Great. Thank you, Karen.
You're welcome.
So Karen, have you spoken to this group before? Deborah, I'm sorry.
So this is the first time that Deb is presenting to the committee. Jane Jackson, who's the finance director, she has been with us before for behavioral health. She is the finance director for both of those divisions, but this is the first time Deb has been with us.
So I just want to give her a heads up about the way we do things. So can you see me in your screen, Deb?
Yes, I can, Representative Earth.
So I'm apparently supposed to like wave you to get your attention, hopefully between your breaths. And I'll try to keep an eye on other people as well for their hands being raised. But if other people raise their hands and I don't catch them, feel free to interrupt me.
Okay, thank you, Representative Ver.
Thank you.
With that, I'm going to go ahead and get started because we have a bit to get through today. So I just want to take an opportunity to let you know that Jane Jackson is the finance manager for long-term supports and services, in addition to behavioral health, and she'll be joining us today. Also joining us on the call today and who is available for questions is David Whiters, who's the Director of Information Services here at DHHS, because I'm going to be talking a little bit about information technology at the start of the presentation. And Henry Lipman will also be joining us to go through a couple of the items relative to BEAS when we get there. So with that, I just want to begin with a brief overview of the Division of Long-Term Supports and Services. The division was established in 2017 and includes 3 bureaus. The Bureau of Developmental Services, which has 4 major program areas, which we will discuss later on. The Bureau of Family-Centered Services, which has 3 major programs, which we will get into later on. And the Bureau of Elderly and Adult Services, which has 9 major programs. In state fiscal year 20, the expense for these programs came to $796 million. This represents 32 accounting units over the 3 bureaus. And we will be getting into details around those accounting units and what our SFY 22-23 budget looks like moving forward. So as you've seen in previous presentations, the Division of Long-Term Supports and Services is part of the Human Services and Behavioral Health component within the Department of Health and Human Services. We work in partnership with Medicaid. I believe Henry Lipman yesterday described Medicaid as a team approach. And you will see that out of that $796 million, a good portion of the financing is Medicaid match specific. However, we do have other funding streams, which we will get into and explain in just a moment. When it comes to the Division of Long-Term Supports and Services, the bureaus are brought together because essentially we help people from literally the ages of 0 to 3 with early intervention services, all the way through helping our seniors with nursing facility care and home and community-based supports. In addition, we also support those with developmental disabilities once they exit the school system and go into adult services. So it's a wide range of services, and we have an opportunity to work with a terrific array of providers and area agencies and case management agencies that we'll be talking about as well a little further down the line. So within the Division of Long-Term Supports and Services, we, as I mentioned, a good portion of our funding comes from Medicaid. And that Medicaid funding helps support our 41915C home and community-based waivers, and our federal partners are the Center for Medicare and Medicaid Services. In addition, Medicaid helps cover the nursing facility costs along with our partners from the counties. And we'll be talking more about that when we discuss the Bureau of Elderly and Adult Services. We also have 4 other funding streams that are braided into providing services for seniors and for children and for adults with disabilities. The funding streams include the HRSA funding stream, which we will be referring to as Title V funding. So I know that you've got your acronyms in front of you, so that's HR. We also have the Federal Office for Special Education funding stream, which is our Part C, Early Intervention or Early Supports and Services. We also receive funding from the Administration for Community Living, which includes Title III, II, and IV funding. And we also receive funding from the Administration for Children and Families, which is our Title 20 funding. So we have a wide variety of partners that we have to meet compliance requirements for, whether it's through grant funding or Medicaid funding. And we have a terrific team that works very hard to make sure that we ensure that we protect those matches and those dollars as they come into the state. So we do have some key challenges, and I think some of the challenges will be reminiscent of the challenges that you have heard about to date from other divisions within the Department of Health and Human Services. I wanted to focus in on workforce to begin with. Within the workforce, I would break it up into two different categories. Category number one would be workforce shortages within our bureaus, which is resulting in challenges for operations and oversight. In the Division of Long-Term Supports and Services, we have a total of 153 positions. 131 positions are filled right now and occupied, and 22 are vacant. So when I take a look at what we need to achieve when it comes to transactions, operations, and transformation, it makes it rather difficult to move into transformation and building new programs and creating partnerships with our stakeholder community to advance our services because of the fact that we, quite frankly, are understaffed at this point in time. And we spend a lot of time focusing on our transactions and operations to protect our match with Medicaid, as well as to ensure that we continue to get our grant funding from our federal partners. As an example, the Bureau for Family-Centered Services has been operating at a 41% vacancy rate for the past 6 months. This is due to a high retirement rate. The Division of Long-Term Supports and Services, like the rest of the department, has seen a significant number of retirements during the COVID epidemic. And I know that Deputy Commissioner Weaver spoke to some of the challenges that we've had in terms of staffing. Another area that I know that many of you have heard about, especially relative to COVID, because COVID has really put a spotlight on workforce capacity issues. And that comes to us being able to appropriately staff our nursing facilities, as well as our home and community-based services. We continue to have issues in terms of attracting individuals to this sector or to this segment to be employed and to be able to work with our provider community to deliver services. Another area that we have faced key challenges on is relative to information technology, and I'm going to get very specific about that in the next couple of slides. But the bottom line is that the Bureau of Elderly and Adult Services is working with a 23-year-old system right now to be able to administer many of our programs, including our adult protective services programs. And this is posing problems moving forward, and we have a capital request in that. For our Bureau of Developmental Services, we have a series of disparate and aged systems. One of the systems that we work with our area agency system is New Hampshire Leads, and that dates from 1998. We also have what's known as a budget tracking system, which dates from 2007. So when you take a look at our Bureau supports, we are definitely challenged when it comes to processing the work and getting the access to data and information to inform policy making. Lastly, we have multiple funding streams, and it's a challenge relative to compliance and oversight because we need to make sure at all costs that we are delivering quality product and that we are meeting all the requirements set forth in our from our funding partners.
Excuse me, Deborah, I believe Representative Rogers has a question for you.
Yeah, I'm not sure, Deb, if this is the proper place to ask, but when you talk about the workforce and your shortages, is there a rate increase in this budget? I didn't notice or didn't know where to find it, but is there a rate increase for any of your workforce included in here? And if not, did you ask for one?
Okay, so we did zero in within the BEAS budget, and we'll get into it a little bit later on, but just to give you a preview now. 3 areas for rate increases. The first area is case management for our CFI case managers, and that will be part of the CFI case management rate increase. And Representative Rogers, because of the work that you did on the parity committee a couple of years ago, you know that that was a commitment that the department made to move that forward, and we are doing so in this budget request. A second area is for personal care services in the CFI waiver, and we're looking for our rate increase there that we can get into more detail on later on. And then the third area is homemaker services, where we have put in for a rate increase. Those went in the department phase as a prioritized need, and those are included in the governor's budget.
Is that it, Kathy?
Yep.
I also have a question for you, just to, when we get to go into the accounts, would you draw our attention to the accounts that relate to these systems you were talking about?
Yes, absolutely, because they are actually not in the BEAS budget, but they are in the capital budget. So I'm going to quickly go through those
Oh,
now, Representative Burr.
okay.
Okay. So moving forward, there are 4 capital projects. And the first one is the BDS Direct Billing Project. And this is a project that is going to help us meet our corrective action plan with our federal partners for the Centers for Medicare and Medicaid Services. And this FFP is at 90%. And so the net to the state for this project is $100,000. And this will allow us to meet our requirements in terms of the corrective action plan. The second system is the Developmental Services IT remediation system. And again, this is a 90% match, all right, with our federal partners. And the net to the state would be 1.3 million approximately. And this is a project that is of extreme import because these are the systems that date from 1998 and from 2007. And we are hard pressed to provide for compliance, oversight, and operations with our current systems infrastructure. The next system that we have put in as for part of the capital budget is the electronic visit verification system, otherwise known as EVV. And this is required by the 21st Century Cures Act. And for us to be able to deliver this system, it will come once again with a 90% match, and the state net for this one will be $566,000. And this is a mission critical system in that it allows us to be able to take a look at gaps in services. It allows us to affirm that the services are actually being delivered. And it also decreases any potential or opportunity for fraud. And right now, if we do not deliver this, we will be receiving a penalty from our partners from Medicaid that will directly hit the state. And David Whiters is available if you have any questions in regards to this any further. The 2 systems that I'd like to call attention to, because we have done a lot of requirements work and are literally at a point where we could go out and RFP, are the EVV system. Because prior to this, we worked with Mercer. We had an RFP that was put out, and we have defined the systems requirements, and we can move on this very, very quickly and hopefully put ourselves into compliance so we are not looking at a penalty. For the Developmental Services IT remediation system, we have been working with Public Consulting Group, and we've completed systems requirements for this as well. And we are at a point where we could move this forward rapidly to get into actual system builds and to see some relief when it comes to compliance, oversight, and operations. The last system is the BEAS Modernization. And this is a different system in that it is not a Medicaid-based system, but it falls under a 60-40, so it would be a 40% match. So the net to the state would be a little over 4 million. And again, it's a different matching approach.
So is the slide incorrect, or are you talking about a different system?
That slide is correct. It should indicate 40, not 90%, Representative Ruff, and I will make sure that that's adjusted when we submit. I'll resubmit that to Kevin so that you have it. Please know that we have done some extensive work here as well. We've done a full lean analysis where we've defined, measured, analyzed, and figured out what needs to be improved and what controls need to be put in place using the DMAIC model. And it's important to note that if we do not get this system, we believe that we would be looking at hiring an additional 4.5 people to do this work manually. And quite honestly, it would still not help us in terms of getting improved service authorizations, taking a look at caseloads, helping make sure that we can process registry requests for background checks so that nursing facilities can move quickly to be able to hire people so we can process things more effectively. There's a lot of human intensive data entry right now, which comes with thick thumbs and can pose issues down the line. And we believe that there is a far more effective approach that we can take relative to our systems in the Division of Long-Term Supports and Services.
Deborah, I believe Representative Wallner has a question for you.
I do. Deborah, you refer to these as capital projects. Are these in the operating budget, or are they in the capital budget?
These are in the capital budget, Representative.
Okay, thank you. So really, they're not before this committee, they're before the Public Works Committee.
They are, and I wanted to call your attention to it because for us to be able to be effective in our transactions and operations, we need these systems. But for us to be able to transform and to be able to do work that results in better services when it comes to the way that we deliver services, our information technology is a foundation to be able to do that. So when I talk to you about our operations and our budgets here within Division 3, I wanted to call attention and connect to the fact that we need an infrastructure build within long-term supports and services to be able to deliver better services, to be able to work more effectively with our providers, and to consider new ways of delivering services that will result in better quality for the people we serve and efficiencies.
Great, thank you for clearing that up. Thanks.
Just one question related to that, Deborah. Are any aspects of these systems, the installation of these systems, included in the operational budget?
No, this is entirely capital.
Okay, thank you.
All right. And I just want to reach out to David Whiters to see if he is on the line, Kevin, and if he would like to add anything relative to this.
Sure, let me just bring him in.
Thank you.
And Representative Bean is note that Representative Weiler is present now.
And Dave should be in here now.
He would need to unmute himself if he wants to talk, but he is there.
I apologize. Yes, I was just trying to find that mute button. My name is David Wieters, Information Services Director for Health and Human Services. And Deb Sheets actually covered it very, very well. The only addition I have is the Bureau of Elderly and Adult Services Modernization was brought up at the capital project hearing with the Public Works Committee. That project was not in the governor's submittal. It was one of the items that we suggested that the committee consider moving that forward as well, so that we could really address the deferred maintenance that we've had on systems across the board in DHHS, but specifically in long-term supports and services. These systems are critical for them to be able to provide the ongoing operations and maintenance. So without these systems, the operations expenditures are dependent upon them. So we wanted to tie them together, and that's why you're hearing about them today. I don't have anything else to add.
Just to clarify, you're saying that none of these projects were included in the governor's capital?
For clarification, the first three that she referred to, the electronic visit verification system, the IT, the developmental services IT remediation, and I'm going to get the name wrong on the other one.
Electronic visit verification?
The third
Yes,
one.
direct billing, the developmental
And
service,
the BDS direct.
remediation, and the electronic visit verification were included.
Correct.
Was the Bureau of Elderly and Adult Services Modernization, but I do want to call attention to this because I do see this as a mission critical system that is 23 years old. And I think that when you get right down to it, we need the infrastructure to be able to operate BEAS and to be able to ensure that we can operate our APS program.
Thank you for the clarification. I don't think there are any other questions, so go on ahead.
All right. So I'm going to move forward, and I'm also going to talk a little bit about the Alvarez and Marcel report that will be published shortly. And there were some very specific recommendations for the developmental services system. The first was the recommendation that the Bureau of Developmental Services take a look at a waiver redesign. And right now, the developmental disability waiver is a single comprehensive waiver. And the A&M report indicates that the state should consider taking a tiered waiver approach, which is something that when it is published, you can take a look at and get some additional information on. And the report also asks us to consider developing tiered reimbursement rates. Now, I think it's important to note that the DD waiver in SFY 20 was about 280.2 million. It's also interesting to note there that 0.7% of the DD population account for 5% of the total DD waiver budget. And those individuals that account for that higher percentage of spend are individuals that receive intensive treatment services and residential options. Right now, we have quite a few out-of-state placements, and related to the waiver redesign and the reimbursement rates is the recommendation that A&M has made that we develop in-state intensive treatment services. And I believe that that is an important factor moving forward because it will allow us to keep individuals in state with their natural supports. It will allow us to develop this higher level, high need service and hopefully do so at a cost that is less than sending people out of state for services as well. It will also help the Bureau develop in cooperation with the area agencies and providers a continuum of care that takes into account serving the highest level of highest need. And again, I'm going to circle back to the fact that the A&M recommendation really emphasizes the import of having an information technology system to support our operations so that we in turn can support transformation, which would include a waiver redesigned tiered waivers, as well as tiered reimbursement rates. So all of these are directly connected, and when the report comes out, you will be able to read that, which will tie into the HB2 $10 million figure that Representative Wallner was asking about yesterday with Director Lippman.
So can you provide any insight as to why we don't have that report when we're expected to fund $10 million to implement that report?
I think
Jump
it's a
in if
matter
you
of
want.
just being posted, but I'd ask Karen Rounds to just give an update on where that is.
There was some finalization that needed to happen to it. And so it is just about finalized. I really hope that it will be public this week.
Okay, I mean, I don't know what you mean by public, Karen, because we're not really the public.
Yeah, you are the public. Anything I provide to you is public information.
Okay. I mean, it's a little frustrating to us that we have to consider a $10 million expense and we can't see what's behind it.
I understand.
Okay. Mr. Representative Weiler has a question, I believe.
Thank you, Mr. Chairman. From experience in the past with reports that are slow in being published and sometimes not totally available, and what I've discovered is that you're negotiating with people to change what was written because it was too critical, or it might have done something, might have said something like, you got too many middle managers, or you paying your people too much. So those are the kind of things that we don't want to see exposed. This may not be the case at all, but it's what my experience in the past has told me. When there's a report that is slow to come to those of us that paid for it, it's because of these reasons that there's negotiations going on to change. And that's, I'm sorry, that's my suspicions.
And I can certainly appreciate that, Representative, but I can assure you that that's not what's happening. There's definitely not any negotiation around what the report says.
Thank you.
You're welcome.
So to summarize, what we have is a case of, oops, my apologies. What we have is the report indicating that we have inadequate information technology to collect and analyze data, and that we have inadequate controls for aligning services to assess need, which means that there may be instances where we may be overserving somebody or underserving somebody. And what we want to do is make sure that every individual gets the services that they need based on their level of care. And the recommendations from Alvarez and Marcel are very, very specific in terms of what the department can do to address those issues. And we do have some gaps in system controls that are outlined in the report as well. And again, the Information Technology Foundation, the waiver redesign, and the tiered reimbursement rates will go a long way to try and remediate some of this. And in terms of a continuum of care, we are unable to deliver a lot of necessary intensive treatment services in state.
So question related to the $10 million for the Alvarez and Marcel and the fact that the governor didn't include the more expensive of your capital projects, the most expensive, I guess. Which one would you prioritize? The Alvarez stuff or the federal, the Bureau of Elderly and Adult Services Modernization technology?
Okay, so Representative Earth, I'd like to just go back and indicate that the governor did prioritize BDS developmental services, IT remediation, which is noted here by Alvarez and Marcel, and electronic visit verification. My understanding is that the BEAS modernization was not included, and I would just like to lean into David to see if he has anything to add.
Well, just to clarify, so you're saying that all 4 of those systems are part of the A&M report?
No.
But okay, so I'm not quite sure what your comment, how your comment answered my question. Let me rephrase my question.
Okay.
The A&M is budgeted at about $10 million in HB2. The BEAS, which if I understand, the Bureau of Elderly and Adult Services Modernization, which if I understood you correctly, was not in the governor's budget, capital budget appropriation. And that's roughly, what, 40%, 60% of $8 million. So it's several $1 million. It's not insubstantial. I'm just wondering, which do you prioritize more highly? The things that the A&M report is talking about, or this particular system that was not included in the capital projects?
So the A&M report calls attention to and prioritizes the developmental services IT remediation. All right, and points that out as being essential to conduct system transformation.
Yeah.
That is included in the capital projects.
I got that. What about the Bureau of Elderly and Adult Services Modernization system?
Are you asking me to choose which one of my children I want?
Well, so the developmental, the first one is not a $10 million system. It is like $1 million.
BDS direct billing has a state net of 100K.
Right.
The developmental services IT remediation has a state net of 1.3 million.
Right. So that's not inconsequential, but it's way less than $10 million. So of the other $9 million of the A&M report, is the other 9 million or most of it a higher priority than for your department?
Okay, my understanding, and correct me if I'm wrong, and I'll yield to Karen on this, is that the operations of the 10 million does not include the IT component, please, correct, Karen? That is capital.
I believe that's correct. And if you were asking the department to prioritize, we would say that the implementation of what is in the A&M report is a priority for the department.
Okay, so this is not in the A&M report, this particular system.
No, so what's in the report is the developmental disabilities piece, and that is within the capital budget.
I got that, but the Bureau of Elderly and Adult Services Modernization piece is not in the report.
No,
it is not in the A&M report.
Okay, Thank you. And Representative Weiler has a question.
Thank you, Mr. Chairman. So we have a Department of Information Technology. Were they involved at all in any of these decisions of not funding this? I guess Mr. Wieters, I don't know whether he's directly employed by them or he's just their coordinator or how it works? The full department of IT, were they any support or were they any advice on this?
Thank you, Representative Weiler and Mr. Chair. That's a good question. We certainly, we coordinate with the Department of Information Technology, and we create what's called an Agency Information Technology Strategic Plan with them. And then what happens is Commissioner Goulet actually works to prioritize those projects with the department as well as across the whole state, and then submits those projects for review by the governor's office. We certainly have prioritized, and as Representative Erf indicated, which one would we do first, which one would we do second. BDS direct billing was not at the top of the list, so we basically got the top 11 projects moved forward through the governor's process for the House to review in the Public Works Committee. And Commissioner Goulet and myself presented on this past Friday on those projects together. So they certainly, we integrate, we leverage DOIT. We can't live without them. My role for the department is to coordinate our strategic plan, as well as our security, data warehousing, and overall application lifecycle management.
Thank you, Mr. Wieters.
Representative Wallner, you have a question?
Yes, I do. I was wondering, how was the disabilities community and maybe the area agencies involved in the development of this report?
So the report calls for extreme comprehensive stakeholder engagement over at least a one-year period with the area agency system and with providers, and most importantly, with the individuals that receive these services. As many of you are aware, that the disability community has long maintained nothing about us without us. And part of the A&M report takes that into consideration. And we have a one-year stakeholder engagement period, which will help with systems requirements, which will help with the way that we redesign the waivers. We want input. We want to work collaboratively to bring the system to the next level. And that is the intent, and that is clearly outlined in the A&M report. And it's something the commissioner felt very strongly about.
Thank you, Deb. I appreciate that.
I'm sorry, feel free to go on.
No, that was my question.
Oh, no, I was talking to Deborah.
All right. So what I wanted to do is give you this landscape approach look at where we are within the Division of Long-Term Supports and Services. And then I'm going to go through each of the bureaus and ask my bureau chiefs to join us during that, during those presentations. But again, what I wanted to do is to give you context for the A&M recommendation and how that fits with our budgeting approach in SFY 22-23. And also the need for information technology and infrastructure builds and how that fits in. So thank you for your patience. And as soon as the report is up, I'm sure that there will be a lot of people reviewing that to see the good that can come out of those recommendations. So thank you.
Just let me excuse myself for one moment. Representative Edders, you want to step into the driver's seat?
Oh, no, you're doing great.
Okay.
So next, what I would like to do is review the Bureau of Elderly and Adult Services. And what I'd like to do is ask Kevin if he could bring Wendy Altman in, as well as Medicaid Director Henry Lipman as well to join us around that. And I want to thank David for joining us for the first portion of the presentation. So the Bureau of Elderly and Adult Services has a responsibility and a mission to help provide comprehensive and coordinated services for older adults 60 plus, as well as adults with disabilities that range in age from 18 to 59. The state serves as the designated state agency on aging under the Older Americans Act. And what we do is we work very hard in partnership with case management agencies and providers to ensure the rights, safety, independence, and dignity of adults. And we do our absolute best to support people and prevent abuse, neglect, and exploitation. We administer the choices for Independence Home and Community-Based 1915C waiver that you will recall is one of the 4 1915C waivers within the Division of Long-Term Supports and Services. And we work very hard to set policy and program implementation for other funding streams that we discussed earlier on. I think it is very important to take a look at where we are as a state and our changing demographics. I think that right now, when you take a look at this in front of you, you can see that New Hampshire is graying. And by 2030, over 1/3 of New Hampshire's population will be over 65 years of age. And when you take a look at the demographics, the number of 85 plus increases significantly as well. So between now and 2050, we are looking at an older New Hampshire. And what we want to do is we want to ensure that people have the right to choose the types of services they want and how they want to live their lives, whether it be in the home and community, or whether eventually it be through assisted living or nursing facilities as part of the continuum of care. I wanted to explain a little bit about BEAS operations and how we are organized. And this gives you an idea of the lift that we have as an operation. We have a long-term care policy unit, which has 7 staff, and they provide contract oversight for 53 contracts. They do grant management. They provide oversight for the Care Path and Service Link programs, which I will discuss very briefly moving forward. And they are responsible for program coordination, training, and technical assistance. We also have the State Unit on Aging, which includes 2 staff, the Bureau Chief Wendy Altman, and an administrative assistant, and we are responsible for ensuring that we have a state plan on aging. We are responsible for CFI waiver management, as well as public partner correspondence and other items. We also have the Adult Protective Services group, which has 61 staff across our district offices, and they are responsible for intaking APS cases, the state registry, investigations for somebody who may be at risk or be in harm's way, whether it be financially or for the way that they are living their lives independently. And they do a lot of outreach and efforts in education and training so that we get the appropriate level of reporting to protect people. And then we also have a long-term care eligibility unit that provides the medical eligibility for the level of care for people who are applying for and eventually receiving services upon approval. We also have an information systems group that includes 4 staff that help with help desk support, provider relations, and reports and analysis for our ongoing operations within BEAS.
Is the long-term care medical facility an actual facility that does long-term care, or you just where the processing happens?
It's where the processing happens, Representative Earth.
Okay, thank you.
Okay, but direct service delivery is through our Adult Protective Services, and those are 61 individuals that work directly with people at risk. Okay. So in terms of the way that we are organized, as I said, the Adult Protective Services, those are state employees. They work out of the 11 district offices. For the Choices for Independence waiver, we work with independent organizations, senior centers, nutrition providers, assisted living providers, and a variety of community-based organizations. We have 221 enrolled providers at statewide level and at the regional level. And we have 1 contract for what's known as PASSAR or level of care reviews. For elderly and adult service providers that are separate from our Medicaid CFI waiver, we receive our funding through the Older Americans Act and through social services block grants. And again, we lean into independent organizations, community action agencies, senior centers, nutrition providers, and area agencies. And we have 45 contracted providers. And most of them cover a particular county, and 13 do offer services statewide. And of course, most of you are familiar with the collaboration and long history that we have of working with our nursing facilities, with our counties, and with our for-profit and nonprofit nursing facilities. We currently have 71 nursing facilities, and of course, 11 of those are operated by the counties. And then we also have ServiceLink Aging and Disability Resource Centers, and these are independent providers. They are 501c3s. We have 7 contracts, and they work in 13 locations statewide, and they are responsible for referrals and for things like Medicare counseling and things like that that we'll get into a little bit further later on.
Representative Rogers has a question for you.
Yeah, Deb, you told us what your vacancy was before, but what kind of vacancy do you have with the Adult Protective Services? Is that full, or do you have vacancies there?
Adult Protective Services is full, and during the hiring freeze, that was prioritized for maintaining, keeping that in place. We needed that safety net, especially during COVID, so they are fully staffed.
And on the delivery service with your providers, do you know what kind of vacancy rate the providers have, or is that something you're not aware of?
I don't know if I would refer to it as a vacancy rate, but I would refer to it as a workforce fulfillment rate.
Okay.
And so, for example, I'm sure that my colleagues and partners at the nursing facilities are going to be very clear about the fact that they are having difficulty getting staff to be able to deliver services. Just as I think if you spoke with GSIL or other personal care service providers or home health agencies, they too are having trouble attracting workforce in the home and community-based setting as well.
But you don't have any quantitative numbers on how bad it is, do you?
I can take a look at that, but I think that they would definitely
have it. Okay.
Numbers. Yeah, they would
Thank
definitely have the numbers. So moving forward, I mentioned that we had 9 major program areas, and I'm going to go through these pretty quickly. The first is the Choices for Independence Waiver, and these are people that are found eligible for waiver services, and the services include case management, personal care. You could get a mid-level range of care, which is your assisted living facilities, supported housing, non-medical transportation. All of these are listed here. And these are older adults and adults with disabilities that choose to remain at home and in their community rather than getting nursing facility care. And that is an option that we provide as a waiver to our state plan services. And it's something that many, many, many people choose to do. They choose to stay in their home and their community. The next program area is Adult Protective Services, which I've explained in some detail already. Then we have what's the Administration on Aging, or Title III programs. And these are the programs that you've heard a lot about during the COVID crisis. These are the home delivered meals. These are family caregiver supports, Medicare counseling, adult day services, and several prevention programs that we have. And these are for individuals who are 60 or older, but are not Medicaid eligible. And these are individuals that have to demonstrate a need for services and are in social and economic need. Then we have what's known as Social Services Block Grant, otherwise known as Title 20 services. And again, the services include home delivered meals, home health services, adult day services. And these again are for 60 and older, and also adults between 18 and 59 with chronic illness or physical disability who are not on Medicaid.
I think Representative Wilder's a question, Deb.
Excuse me, thank you. Home delivered meals. Does this include the Meals on Wheels, people that are sort of independently financed?
Yes, Representative Weiler, this does include Meals on Wheels.
So does the state give them a stipend?
The state contributes a portion as well as our federal partners.
Thank you.
Kathy, do you have another question, or is your hand is still up? There you go. Sorry, continue.
Okay. Moving forward, we also have the Service Link Resource Centers. Again, they serve statewide in various regions, and they are responsible for information referral. They do person-centered options counseling. They provide oversight for the New Hampshire Family Caregiver Program. They do Senior Medicare Patrol, which helps prevent fraud and make sure that our Medicare beneficiaries are aware of what their benefits are. And then we also do veteran-directed home and community-based services as well through our ServiceLink resource centers. It's important to know that people of all ages, disabilities, and income levels can come through our ServiceLink resource centers, as this is a no wrong door approach. And lastly, we have our nursing facility level of care. And again, 71 nursing facilities, 11 are operated by the counties. Our approach here is to make sure that those who meet a nursing facility level of care and are unable to remain safely at home or in the community gain admittance, and we partner very closely with the counties on assuring that these services are delivered. I also think it's important to note here that this is a team approach here at DLTSS. The Division of Medicaid Services 2 times per year sets the nursing facility rates. And also our Health Facilities Administration and Program Integrity also play a role relative to licensing. And during the COVID crisis, there was an awful lot of support and movement forward from all parts of the department for our nursing facilities.
Representative Edwards has a question, Deb. He's on mute.
I'm used to leaving it off mute. Okay, so thank you, Mr. Chairman. My question is on the nursing facilities. Earlier on, we saw a slide that showed a tremendous growth rate in the number of people 85 plus. And so it just makes me curious to what extent you have a 10-year plan for the number of beds we need in a nursing home, and to what extent that 10-year plan is coordinated and owned at the county level. And I ask that because our most recent administrator at Rockingham did not have a 10-year plan. And just so it seems to me like we're falling behind on capital requests. And I'd like you to tell me if I'm missing something, or if we are in fact falling behind.
Okay. So Representative Edwards, that's a very good question, and thank you for bringing it up. I think what we're doing now is we are meeting on a regular basis, once again, with our nursing facilities and county partners. I know that Representative Weiler has joined that committee meeting, and I think that shall be part of the discussion moving forward. I think during the COVID crisis, we are actually looking, and I think, the nursing facilities would definitely be able to speak to you about this, is that we're looking at potentially a lower census because of outbreaks, and the COVID units had higher intensity of care and things like that. All of this will need to be considered moving forward in cooperation with the counties and with the nursing facilities. And I know that for example, we have a meeting this Friday, the 12th, where some of this will be discussed, and this can be a partnership moving forward.
So follow up, if I may. So I think what I hear you say is, in response to my question, is there isn't currently a 10-year plan with a fixed bed count that we know that we should be planning on, but that you anticipate a process to arrive at one. And I would like to think in a 10-year plan, we've sort of moved beyond pandemic planning.
What I would say is I don't want to overcommit, but I think that has got to be part of the dialogue we have with the counties moving forward, sir.
Feel free to continue. Thanks.
Mm-hmm. So with that, I'd like to give Henry Lipman an opportunity to walk us through NFQA, MQIP, and ProShare, which are 3 acronyms that have a deep impact on where we are with our work with the counties and with the county share.
Thank you, Deb. Thank you for the opportunity to present again to the committee. So the NFQA tax is sort of the beginning point of trying to bring additional monies to support nursing facilities. And the question, actually, before I start though, just in where we ended up last time, I had trying to recall whether the moratorium on nursing home beds, which have historically been a legislative action is still in place. I don't know if Karen, if you can refresh my memory on that or not, but
I believe that it is, but I believe that it is.
Edwards, going back to the 1990s, there's been a moratorium on adding new beds, and I think the demographic pressures are getting that to be considered in terms of for long-term planning, because it's been a while since that's been considered. But the NFQA, sorry.
Excuse me, before you continue, didn't you just approve new beds out on Seacoast? I don't mean you necessarily, but the state.
I'm not aware of that project representative.
Okay, I believe Representative Edwards has a question.
So thank you for educating me that the legislature's imposed a bed count moratorium. Do you need anything in HB2 to empower you to do planning? Because I think planning for beds 10 years out is maybe different than building them, and it starts with a plan. So do you need anything from us in HB2 to allow you to plan?
So I guess I would like to work through Karen to consult with the commissioner and circle back to you on that, if that's all right.
Sure.
So in terms of the NFQA tax, it's sort of a beginning point to be able to draw additional funds to fill in the gap between what Medicaid pays and the costs that nursing facilities incur. And so there is a tax that of 5.5% that is applied to patient service revenues, and that tax is then paid to the DRA. It is transferred to the department, and the department draws down a federal match. Typically it's 50-50. During the pandemic, it is 56.2% federal match. That extra 6.2% on the federal portion, starting, I believe it was in the first quarter of the pandemic, the state passed that money directly back to the nursing facilities, didn't retain any of that. But that tax, if you could go to the next slide, please, funds what is the payment, which is known as the Medicaid Quality Assessment Program payment. And this program's been in place for quite a long time. There's been refinements to it as CMS has reviewed and refined their regulations. The most recent refinement happened in last fiscal year. It didn't change the amount that was collected or paid out. It basically just made sure that the tax and the payment was made by the state before the federal match was drawn. And so that had a bit of a timing impact on nursing facilities, but not a lot, but it was needed to be addressed in order to be current with current regulations. Let me stop there. If there's any questions on those two pieces that sort of come together to fill in part of the gap. Now, this particular payment goes to both private nursing homes and to the county nursing facilities.
Is any of this payment timing related to the pro share payment timing transfers?
No.
Okay, thank you. Anybody else have any questions? Looks like you're okay, Henry, to go ahead.
Okay. If not, I think we've kind of covered both the tax and this particular payment. And I think, again, to the benefit of the nursing facilities, the public health emergency, to the extent it continues as expected, those additional payments have amounted to about 1.3 million a quarter to the nursing facilities. Those will continue to the if the public health emergency runs to the end of this calendar year as expected, would also mean that the enhanced federal match would continue to go to the nursing facilities. The next slide here talks about ProShare 1 and ProShare 2. I know from having been to various county meetings over the years that this is a really important part. When I first came to the department in 2017, there was some restructuring of ProShare 1 and ProShare that had to be done so that there would not be a reduction in the amount of money being able to draw. Historically, the transaction was generated first from the state providing money to the counties and the counties keeping a portion and then sending a portion back. The feds came around in 2018 and 19, allowed us to restructure it to draw down additional monies, but with the caveat that the caveat that came through that we had to have the federal, the non-federal share come from the counties itself with respect to ProShare 1, and that ProShare 2 counties were converted to what they call a certified public expenditure. But from a big picture standpoint, what ProShare is intended to do is, after you've made the per diem payment, after you've made the MQIP payment, is to fill in the gap between, in the case of ProShare 1, what Medicare would otherwise pay and what those payments are. So if you will, the ProShare is intended to try to fill in that last bit of gap. For ProShare 2, it's essentially the same kind of concept, but in that instance, we're comparing Medicaid costs to Medicaid payments. And again, the difference that you're trying to fill in is the gap between cost and payments. Each year that we do a ProShare transaction, we go through a process of state plan amendments. We're currently in that phase right now. CMS has identified some changes that they want in the calculation. We're still negotiating around those changes. I know a number of counties have approached us about getting a sense of kind of where things stand, and later this week we're going to be sharing what we know by county in terms of the calculations. But the issues that they've raised in the current ProShare that they hadn't raised in prior years is, I said that in both ProShare 1 and ProShare 2, you're comparing cost or payments to what Medicaid or Medicare would otherwise pay. And so what they're saying now is, with respect to what Medicare or Medicaid pays, that in particular, there is a portion when Medicare determines what a facility should be paid that the patient also contributes. And they're saying that with respect to ProShare, that the payments that patients make towards their care, that has to be counted towards what payments the facilities are being credited for receiving. Historically, last cycle, the ProShare payment was based on what just the state paid or what Medicare would have otherwise paid as a direct payment, not taking into account the patient payment. They've also asked us to look at a different methodology for the upper payment limit. We've been working with CMS on looking at some different ways to compensate for what changes they're looking to make, and are continuing to work on that. Again, I think what I can do at this point and what we intend to do is, based on where we are in the process, is to share with the county nursing facilities where we stand at the moment, and that we're going to continue to work over the next several months to try to improve upon where they're sort of directing us at this point. Let me pause there. I know Representative, you and I have had some conversations, so hopefully a little of this is ringing true to you. It's a little bit complicated, but I think if you keep the simple thing in mind here, that this payment's intended to fill in that last gap between either what Medicaid paid or what Medicare paid. And what's going on right now is a redefinition of what either Medicare or Medicaid paid from the standpoint of the feds in terms of looking at what's matchable. The positive news here, I guess, in terms of the enhanced FMAP is that with respect to the ProShare 1 counties that, assuming the public health emergency is still in effect, which I think it will be for sure, when it comes to the June payment, that it won't be 50% that has to be raised, it will be the 43.8%. So let me stop there. That was a lot to put into that slide. See if there are questions.
Anybody else have any questions? Henry's been kind enough to answer a lot of mine previously. I guess you're good to go, Mr. Lippman.
Okay. Deb, I think that's the last slide, or
Right. The only thing that I'd just like to call attention to before I advance to caseloads is that as we go through the accounting units in 2154 and 504, programmatically, what we have done is we have worked with a nursing facility to repurpose 27 beds to create a geropsychiatric unit. And our intent in repurposing these 27 beds is that this will allow us to be able to create a continuum of care where we will be able to move people from New Hampshire Hospital into this unit and thereby provide additional capacity to move people out of the ED into New Hampshire Hospital. And this way we'll ensure that people are getting the right level of care and support in the geropsychiatric unit that will be established with the repurposing of these 27 beds. And we are hoping to have that up and running and operational at the start of the upcoming fiscal year. And that is included in 504 in the atypicals. So just make a note of that. So moving forward.
Is that what I might have heard about a unit out on the seacoast?
Yep, I am assuming that is what you are speaking to, but it's a very important capacity build for a continuum of care. And that is noted in 504.
I think Representative Edwards has a question for you.
So I think Ms. Sheets may have just answered it. I was just curious of the physical location where those 27 beds will be.
It's Oceanside. That is the nursing facility that we are partnering with.
And that's I'm sorry, I'm unfamiliar. So Oceanside is a private nursing home, and they are actually constructing, expanding their facility to create physical space for 27 beds, and then they're going to worry about staffing it?
What they are doing is they have the 27 beds there, and are repurposing those 27 beds. And they have brought in a geri-psych specialist and are getting the staffing lined up to support that approach.
And what town is Oceanside?
I believe it is Hampton or Northampton. Wendy, can you confirm for me? I know I drive by it frequently.
Yes, it's in Hampton.
Hampton. Mm-hmm.
Yep.
Good to go. Thank you.
All right. So next, I just wanted to review some basic caseload figures unduplicated. As you can tell with APS, we had seen an upward trend with the exception of 2020. The case reporting is down. We attribute this to COVID. Just to be aware that we have done a tremendous outreach effort to try and get communities, neighbors, helping neighbors, partnering to be able to keep the case reporting up. And on our website, you will see a weekly count. We track this regularly to make sure that we are getting as much eyes on and as much community collaboration to ensure that nobody is at risk despite COVID, and despite the fact that people have been in their homes and not as many people in and out of the homes of the people that we support in the community. The CFI shows an upward trend, an enrollment trend, which we would expect with or without COVID based on the growing population here in New Hampshire of seniors. Nursing facilities, you'll see that the census is down in from 2019 to 20. We could contribute that to COVID. All right, in terms of the fact that there were outbreaks and the inability to place people there. And I think that, you know, as things move forward, we would be taking a good hard look at that relative to rate setting and a number of other factors. When you take a look at our Title III and Title 20 programs, you will see that this is down. And I believe the reason that this is down is because of primarily workforce issues in terms of the delivery of these services. And when you have issues getting individuals to deliver those services, it means that you're going to see a reduce in census there. And then for our service link, our census is expectedly growing because New Hampshire's population is growing. And we're seeing a growth in everything from Medicare counseling to veterans programs. And this is to be fully expected. For key accomplishments, I think that what you'll do is you'll see a trend throughout this as well as the next two bureaus. For BEAS, we have worked very much so on a state plan on aging, and we continue to work very collaboratively with the Governor's State Commission on Aging. The idea is to help prepare the state for this growing population of seniors and to be prepared for 2030 and to be prepared for 2050. And the Governor's State Commission on Aging has a leadership position there, and the State Plan on Aging is housed on the department's website. And if you would like to look at that, it's easily accessible. The other key accomplishments we have are specific to COVID-19. We have worked very cooperatively and collaboratively with our providers in the community, as well as our CMS partners in the submission of an Appendix K, which allows us to get federal approval for greater flexibilities during the public health emergency. And most importantly, we worked with New Hampshire Employment Security and the provider community to stand up the long-term care stabilization program, which provided stipends to ensure that people stayed in place in their positions during the height of the COVID emergency. We have received a tremendous amount of funding through our title programs that we have made numerous contract amendments to push out dollars to help support Meals on Wheels, adult day services, and Service Links program as an example. And previously I mentioned the Adult Protective Services Outreach Campaign. For key challenges, I go back to the information technology. It's critical for us to be able to conduct our business at a transaction and operational level. And it's critical for us to be able to do system transformation moving forward. Workforce. We continue to struggle with capacity in both our nursing facilities and in home and community-based services. And in terms of system transformation, it's very difficult for us to move system transformation forward unless we have the staff in place and we filled up the vacancy rates moving forward within the Bureau of Elderly and Adult Services. And this is terribly important because we need to prepare and to innovate when it comes to aging services. I believe that.
I'm sorry, Sharon, go ahead.
Thank you very much. So the last box here, public health emergency funding and services outreach. Do we have a time frame for that?
The public health emergency funding has been coming through our federal partners. And as you, for example, if you were to look at the GNC agenda, you'll see that a lot of them went through as informational, and we've been pushing that funding out as we receive it to our providers in the community.
But do we know, pardon me, so do we know when it ends? Is there a time frame?
Anything that we have received, we have pushed through in contracting. As you know, our federal partners have put through, are in the process of putting through additional relief packages. We will need to examine that and see if there's any further aid that will be coming our way.
So right now it's been a one-time Pell money. Okay, thank you very much.
Mm-hmm.
Representative Edwards, you have a question?
Meals, thank you, Mr. Chairman. Meals on Wheels in Manchester. I assume that there's a kitchen somewhere that supports the cooking and preparation of the meals, puts them into some sort of vehicle, and then drops them off. Is that basically the way that works?
I'm going to ask Wendy Altman to speak to that because I am not real familiar with the Manchester approach and what's going on there.
Okay, and just to foreshadow where I'm going, in the Sununu Center, there's a kitchen that it seems to be able to produce a lot more meals than what they actually are. And I'm just wondering if there's a way to leverage existing resources. I'd like to know where Manchester-based Meals on Wheels are getting their meals.
Wendy, can you speak to this, please?
Yeah, so good afternoon, Chair and Committee. Again, my name is Wendy Altman. I'm the Bureau Chief at the Bureau of Elderly and Adult Services. And in relation to your question, Mr. Edwards, in Manchester, there are several different sites and in the surrounding area around Manchester. Many of them do have kitchens where they either prep home delivered meals or they actually cook and prepare the meals. So some of our nutrition providers use vendors who bring in prepared food and they heat it and prepare it for delivery or for what we call congregant meals. And the congregant meals has been suspended since the public health emergency, but they still utilize the kitchen and the area and the workers to prepare those meals and put them in the warmers that they need to go out on the road and deliver the meals to people's homes.
Thank you. So we're using vendors in Manchester now and not state assets. We're contracting out for vendors.
Correct.
All right. So I don't know if anyone
Can't hear you. There you go. Do you have another question, Sharon? Are you all set? I think you're good to go, Deb.
All right, thank you. So I did take a look at the workload benchmarks and I just want to share a little bit here. I focused on adult protective services because it is so terribly critical to the way that we process and protect people. So the workload is that we process all accurately completed registry requests on a timely basis per rule. And as you know, before somebody hires somebody to bring them into a nursing facility, for example, they would need to do the background check against the registry. So our quality standard is that we respond within 5 days to registry requests 100% of the time. And right now, with the exception of a few periods during the COVID crisis, we were hitting that as well as we could. And we will continue to work towards that quality standard moving forward. The second one is that Adult Protective Services initiates an investigation within 72 hours of a report. And I just wanted to share that in state fiscal year 20, our timeframe was at 100%. Our intent is always to be able to respond within 100% on this one. Please know that level 1 is the highest risk. These come in as a level 1 or a level 2. And if it's a level 1, we aim to get in the home within 24 hours or less, moving on that. And then the last one is the workload relative to the level of care determination process. We look to determine and complete a level of care determination within 60 days. And right now we are working within a 95% benchmark. Our quality standard is to get 100% of the level of care determinations processed within 60 days of intake. The eligibility unit and the COVID crisis made that difficult at times, but we are working towards getting back up to 100% in terms of our benchmarking. And that is something that we are constantly looking at and considering relative to improvement. So we took a look at the incremental and decremented budget outcome. If we were to receive a 5% increase, we would apply that 5% increase to CFR waiver rates for the adult day service program and home health. which could potentially assist with improving workforce capacity development and would ensure greater consumer satisfaction and supports. We would look to hire 3 additional staff positions to 1, work on CFI waiver administration and improve customer service for the eligibility processing I had mentioned, where we're at a 95% rate. And we would also use it for grant management and oversight. And lastly, we would look at hiring 2 additional APS staff, Adult Protective Services staff, to improve the intake and registry processing, because we are beginning to closely bump up against what our current staffing can handle. And if I had that 5%, I'd be planning now for it.
Representative Wallner has a question for you.
Yes.
Deb, I just wondered if any of these were in your prioritized needs.
They were not in the prioritized needs, but the prioritized needs clearly indicated the rate increases for case management, for personal care services, and for homemaker services.
Thank you. Could I ask one more question?
Of course.
I wondered, what kind of a caseload are your adult protective service staff carrying?
Wendy, do you have that figure offhand?
Hi, we'd have to get back to you. Those are numbers that we're running this week. Typically in the past, on average, depending on the area of the state and the intakes coming in, it could run between 10 to 20 cases per worker.
Thank you.
And it varies again by area of the state based on where I'm from. Okay. If the budget were decreased, we would have to reduce non-Medicaid billable services, and we would run into a risk of non-compliance for grant waiver and other federal funding, which could result in a loss of Medicaid federal funds or recoupment moving forward. And with that, I'm going to hand it over to Karen Rounds.
Great, thank you, Deb. I'm gonna go ahead and take over sharing. Okay. So this budget, as you can see here, is quite a large budget, most of it being related to nursing home and accounting unit 2152, which we will get to in just a moment. So that's most of what you are seeing there. And then we can move right into the accounting units for this bureau, which start on page 997 with accounting unit 9250. Okay, and accounting unit 9250 is Adult Protective Service Worker, APSW for short, operations. This is where the employees who are adult protective service workers would be. Okay, not hearing any questions. So the next one is 7872, the admin on aging, which is at the bottom of page 998. It goes on to 999. This is where the Meals on Wheels contracts are.
What is the governor's, it's not a lot of money, but it's a big jump in line, what is that? 40 indirect costs?
So that, I believe that I've provided the information from Department of Administrative Services on how indirect costs are calculated.
Okay. I'll ask Kevin for that.
We don't control what that line ends up being.
Is that true of all your accounts? Sometimes they're in there, sometimes they're not? Because
Correct. It's true of line 40, line 41.
No, I understand that it's true of those lines. What I meant was some accounts have indirect costs, some accounts don't, some accounts have.
Yes, that is true. And I don't remember the formula off the top of my head as to why some of them have them and some of them don't.
Okay.
It's based on a formula.
I'm sure.
But all of the personnel class lines plus 40, 41, and 42 are all determined by administrative services.
Okay. Did somebody else have a question there? I thought I saw a hand, but I guess not. Come on, Karen.
Okay.
Yep.
The next accounting unit is 8917, which is health promotion contract. This is a federal grant.
Representative Wallner raised her hand.
Go ahead, Representative Wallner.
I'm sorry. It's further on, my question.
Okay. All right, the next one is 9255, which is Social Services Block Grant, also known as SSBG.
So you can continue.
All right, the next one is 8925, which is Medicaid Services Grants SHIP.
I would say you can probably continue.
Okay, the next accounting unit is No Wrong Door, which is a grant that is in all likelihood ending, but we have budgeted $1 just in case that grant does end up coming forward. And as I've mentioned, those should all be federal dollars when we do that, and it is, yes. The next one is 3317, Admin on Aging Services Grant, SMEE.
I don't see any hands.
Okay. The next one, 8920, Money Follows the Person. This is also a grant that has pretty much ended, but has the potential of continuing forward. Hence the $2 there.
Okay.
9010 is volunteer activities.
Just out of curiosity, what is that?
That is our senior companion program.
Okay. So the volunteers, obviously, they're not getting paid. It's just to run it. Is that the?
It's a volunteer program where we work collaboratively with the counties, Belknap, Grafton, Hillsborough, Merrimack, Stratford, and Sullivan. And it's a state, federal, private partnership where Belknap is the federally designated contractor, and we put in a certain percentage of money so that we can keep that program going.
Okay. Thanks.
Question?
Oh, I'm
Follow-up?
sorry. Go ahead.
So I didn't hear an answer there. What is the money in that line item actually paying for? Is it paying for personnel? Is it paying for specialty gifts for volunteers?
Wendy, can you explain the state share, please?
Yep, the contract that we have with Belknap Merrimack CAP with these funds pays primarily for mileage reimbursement for those senior companion volunteers to travel to individuals' homes to perform the services.
Okay. The next accounting is 9565, which is Service Link. All right, the next accounting unit is 8918. That's New Hampshire foster grandparents. That program was put into the budget last biennium and is, I believe, suspended in HB2 this biennium for 22-23. I'm sorry.
Okay.
It looks like Representative Woolner might be trying to raise her hand. I'm not
Oh.
sure.
Sorry. Go ahead, MJ.
Thank you. Did the department request funding for this program?
No,
So it was not even requested of the governor.
correct. It was not in the agency budget.
Thank you.
Sharon, excuse me, Karen, I think Sharon has a question for you.
Okay.
I think you're muted, Sharon.
Sorry. So in 9565, the 74 and 102 are sort of inverted. Why is that?
Say that again. Which class line are you looking at?
74 and 102.
Oh, that's, yep, that's the, so I think I've talked about it a little bit. We're moving contracts that are for subrecipients from class 102 into 74 to better track them for the single audit.
Okay, thank you.
You're welcome. All right, the next accounting unit is 8915, which is congregate housing. This is very similar to the program I just talked about here, the New Hampshire foster grandparents. We did not implement the program and the agency did not request funds for it for 22-23.
Go ahead, Mary Jane.
No, Karen just answered my question. Thank you.
You're welcome. I thought you might ask again, so.
You're a mind reader, Karen.
Only occasionally. It's a hard skill to use. The next accounting unit is 8943, which is Alzheimer's and related disorders. Okay. Continuing down, the next accounting unit is 2152. This is the accounting unit where the nursing home payments and the CFI waiver are paid out of. This is also where the county participation is, which is also known as the county cap. So what I'm just going to preempt, I know some of the questions that I'm going to get and talk about it a little bit more. So one of the things that you're going to see here, or that you do see here, is that the general funds are budgeted at $5 million for 22 and 23. The reason for that is that the statute for county cap requires that the state provide a $5 million credit to counties. So that's what we have budgeted, which is the statutory requirement of the $5 million credit to counties. There has been a history of additional general funds being added here. However, they would not be considered a credit under statute. They were just additional general funds that reduced the county contribution. You'll also notice that the overall budget is up about $15 million from 21 to 22, and then it's even funded in 23. And I think Deb spoke to some of that reason, but she can also talk about it more if need be. There is the 3.1% rate increase that happened in 1/1 of 20, and then again on 1/1 of 21. And of course, that rate increase would only be reflected in fiscal year 21 for part of the year. And I wouldn't even say half of the year because payments don't happen immediately for that month. So that is part of that increase. Additionally, there are some rate increases, which I know Deb did talk about, built in for CFI on the 4 CFI lines there. So that is also part of that increase that you're seeing there. So I'll stop there. I'm sure there are some additional questions.
So Karen, one of the questions I got related to that, everything you just said made sense. but you didn't mention the fact that the bed occupancy rates are down and are not anticipated to jump, at least as far as I understand, back up to where they were pre-COVID for a while. Did you account for that, or can you account for that in the total number?
Deb, can you talk about that a little bit? I know there's a couple of factors like the cost report that we use.
Already, I'm actually going to let Henry speak to that because he's actually spoken to the counties about that.
I think Henry actually had to jump, so
okay.
Henry's not with us.
Alrighty. What happens is when we determine the rates, there's a lag on when the rates are on when the occupancy rate is calculated in there. So for the time being, we are good, but moving forward, the census is going to have to be taken into consideration and it will be lower, and we need to take a look at that. And I know that Henry has been talking to the counties about that, and it has been a point of dialogue and will be again, most likely as part of Friday's meeting, perhaps.
Okay. Representative Wallner?
Yes. So Karen, in this proposed budget for 22-23, the governor's budget, there are no rate increases for any of these lines. Is that correct?
No, so there are rate increases for the CFI lines, which Deb, I believe that's 505, 506, and 529.
Okay.
So Representative Wallner, in line 506, home support waiver services, that is where you will find the case management rate increase and the personal care services rate increase.
And how much are those, Deb?
Okay, for case management, you will see a total fund increase of 2956990, and for personal care, 4662102.
And can you tell me what percentage they are?
In terms of,
Like what percentage will the rate be increasing?
I can tell you that I can give you the amount. I don't know the percentage offhand unless Wendy does, but with personal care, 3.1% brought it to 489. And we increased it to 562, which puts it in parity with the state plan. And for the homemaker, the 3.1% brought it to 509. And we increased it to 540 using a cost-based methodology for this service.
Okay. So those two services, case management and personal care. Thank you.
Mm-hmm. And in 529 is the homemaker.
Oh, thank you. Okay, 529 is homemaker. Thank you.
Right, and the homemaker is 84,492.
Okay, great. Thank you.
Representative Wallner?
Thank you. I thought I heard you say, like back with Service Link, that it was not in the agency budget, and it's not in the governor's budget, yet we see a couple $1 million in this budget document. Are there other agencies or other areas in this budget document that were not included in the governor's budget or in the agency budget, yet are still in this budget we look at?
I don't know that I understand the question. When I said that there was something not in the agency or the governor's budget, it was New Hampshire foster grandparents, which is not showing, not budgeted anything in 22-23. And
maybe I misheard. I was looking at Service Link when I heard that.
Oh, okay. Yeah, no, that was
referring to the foster grandparent one.
Yes, I was.
Okay, so I guess that's why it's zeroed out. All right, so
yes,
that was my curiosity. I was looking at Service Link and thinking it wasn't funded, and yet it was. Thank you.
You're welcome.
Looks like you might be good to go, Karen. That wasn't too bad, was it?
No, none of it's too bad. The next one is 2154, which is nursing services. This is not funded with county funds. This is 50-50 general funds, 50 federal funds.
So th- just comparing to the last, well, the current biennium, it looks like it went down.
It did. So part of what's going on here. So the other thing that I should have mentioned, going back to 2152, you just pointed out what I forgot to talk about. Just
Let me help.
atypicals, which are nursing home residents that require some kind of specialized level of care. Like Deb was talking about earlier with the new beds on the seacoast, those are considered atypical beds. During the legislative session in 20 and 21, and I will take full responsibility for not fully understanding the budget at that time. I had been, no excuse, but I'd only been with the department about a year. And so this was an area that I was still definitely learning. And during the legislative phase, 2152 was changed and we moved the atypicals to 2154. And we shouldn't have. They are part of the statute of what the counties are responsible for paying. And so they should not have been moved. So these expenses actually, this class 504, in fiscal, it took me a year to figure out that I messed that up. And so fiscal year 21, we will not expend any of this 3.5 million. It will be paid out of 2152. And going forward, we have budgeted it in 2152.
So that's the half that was reduced in this coming biennium? Is that what you're saying?
Yes, that's what was reduced. That was what was removed, that class line 504. So
Okay.
in fiscal year 20, the actuals were about 7.6 million. So this increase here, the 204 to 221, about 7 or 8 million of that is that atypicals.
So are you doing the line 505 in both?
504 is in both, 505 is not.
Okay, 504 is a nursing home. That's where the atypicals would be in.
Yes.
Okay.
And that's the one that we moved.
That's when you added back into.
Yes, that's the one we put back into 2152, which is where it has historically been. Like I said, it was, I completely own that was a mistake.
So yeah, I'm not worried about the mistake. So that accounts for part of the increase as well?
Yes.
In the budgeted lines there, budget
In
numbers?
line 504 and 2152, yes. And what we can do, Deb created a nice little chart of what the increases are attributed to here on 2152, and we can provide that to the committee. We have already provided it to the counties.
Okay, that'd be great. So then does atypical come out of 2154 going forward?
So going forward, atypicals will be in 2152.
Okay. Okay. So that accounts for part of the reduction
decrease
then
here.
in the next year, the next biennium.
Yep. Yes.
Okay.
Yes.
Just so you know, folks have told me that atypical is in both anyway, so apparently it didn't do too much damage. You're moving it around. We all figured it out.
I think we figured it out, hopefully.
Mary Jane or Representative Wallner?
Yeah, so I just want to go through the numbers just a little bit. So under 2152, 504 nursing home payments, the number on that line is 221 million. And what you're saying is about 10 million of that is from 2154.
7 or 8 million, yes. Yes.
Okay.
But I'm just basing that based on actuals from 2154. We'll get you what was actually budgeted.
Okay, so we'll see how that,
Yes,
how that line went, how line 504 went up and 50 and down here in 2154, the line went down. Okay.
Yes.
Okay. Thank you.
You're welcome. Any other questions on 2154? Okay. The next accounting unit is 2157, which is MQIP payments, which was one of the payments that Henry spoke about earlier. And like I said, he He is no longer able to join us this afternoon, so if there are questions, we may need to just follow up.
So the agency income, that's the tax, is that correct?
That's correct.
And then it gets matched by the feds?
Yes.
And the nursing homes are paying the tax on their occupancy, on their revenue?
Net patient service revenue.
Okay, so on a revenue source of some.
Yes.
Okay.
Yes.
And Representative Wallner, do you have another question or?
No, I'm
Just
sorry.
one with
I
me.
put my hand down. Sorry.
No problem. I think you can go on, Karen. I haven't seen your hands.
All right, the next one is 2161, which is pro share payments. You can see that we've essentially level funded this. As Henry spoke about, we go back to CMS every year and amend the state plan. And so we typically come to fiscal committee every year and change the budget as well. So
Karen, can you begin to explain the relationship between the numbers that are here and the numbers that the counties see?
like why?
Well, so for instance, over the last few years, and this is what one of the things that Henry's been negotiating with the change is this sort of the amount of money is going to come back. But so the money's come into the county, they go to the state and get doubled, and then half traditionally half comes back. That part's going away. I'm just wondering, is this the part that goes up to the county and then gets doubled, or is this the doubled amount? Well, what's the, you know what I'm trying to ask?
I do, and I forget because every year I have to relearn exactly how it goes through the accounting system, how ProShare 1 and ProShare 2 go through, because it's two different ways.
Right.
So if you want, what I can do is we could walk you through that sometime.
That'd be great.
I would need Athena Gagnon as well, because she's been doing it a couple more years than Jane and I have.
Okay.
So.
I just love to understand the relationship between what I see in the state
Yes.
budget and what happens at the county level.
Yes, we can do that. We can set something up.
Thank you. Anybody else? I guess not.
Okay. 2164 is CFI waiver program eligibility. This is where staff are. And the move from 102 to 74 here is the same as I've spoken about earlier.
Okay. Oh, 102 to 104. This piece. Right.
Right. The next one is 2165, which is civil monetary penalties, which is the last accounting unit in this bureau.
What was that number?
I
got it.
Okay.
Okay.
This is actually 100% federal funds. It looks like the accounting unit might have closed incorrectly for 20, so the actuals look a little funny there.
So that doesn't belong there.
The general fund should not be there. That I'm not sure exactly what happened there. A mistake.
That's actually kind of important to me.
All right, so I'm going to go ahead and stop sharing and turn things back over to Deb to cover the next bureau.
Thank you.
So I'm beginning on slide number 33. And I'm going to ask Kevin to bring in Jen Doig, who is the business manager within DLTSS. and Sandy Hunt, who is the Bureau Chief for BDS, and Dee Turney, who is the Bureau Chief for Family Centered Services. And they'll be joining me for the presentation as we walk through this today.
Okay, they're coming over now.
Thank you, Kevin.
Yep.
Oops. Sorry, just trying to catch up there. Alrighty. So to begin with, the Bureau of Developmental Services serves as the state's designated agency, and we are responsible for administering the developmental disability, acquired brain disorder, and in-home supports waivers. And what we do is we work very hard to ensure that the rights, safety, and interdependence of the individuals that we support are respected and that we prevent abuse, neglect, or exploitation. And what we do is we work with a comprehensive community-based service delivery system. Our partners for the majority of our work are the area agencies, and they are in 10 regions throughout the state of New Hampshire. We also work very collaboratively with the Bureau of Family Centered Services for the administration of the Early Supports and Services Programs, which is the early intervention for the children between the ages of 0 to 3. And we provide oversight for the waitlist management for the DD waitlist, which I'm sure most of you are familiar with. So the Bureau of Developmental Services has 23 staff, and we have 12 state contracts. 10 of the state contracts are with the area agencies. One is with the Institute, New Hampshire Institute on Disability, which is with the University of New Hampshire. And then the final contract is with the Brain Injury Association. And again, what we do is we work on the administration of the 31915C waivers for acquired brain disorder, developmental disabilities, and then in-home supports, which is for the children. Our 10 regional area agencies are designated by 171A to provide these services. They do a tremendous job in heavy lifting for the financial management and monitoring in the program. And they work directly with the Bureau on evaluation and quality assurance. And they are responsible for ensuring that every individual that's found eligible for waiver services receives their services. And they are responsible for ensuring for service coordination, personal care service delivery, in-home supports, specialty services, independent living. And they do independent vendor contracts as needed in regards to this. So again, we count on a regional system of 10 nonprofit 501c3s. These are the area agencies. They are designated per RSA 171A and HEM 505. The area agencies are responsible for leadership in planning, providing, and overseeing the services in their communities. And each agency has a catchment areas of towns that they support and serve. Each area agency exercises their own local control. They're governed by a local board of directors, and 1/3 of the board membership must be recipients of BDS services. So this is a very, very solid system that has been in place for well over 30 years. And it continues to evolve as the needs of the people that we serve evolve, as well as the complexity of the types of services we provide evolve. The area agencies work directly with providers for services through a subcontract or service provision. The area agencies work with the provider organizations to deliver the home and community-based care. And there are approximately 70 private providers throughout the state that work with the area agency system to deliver services. So this is a public-private partnership with local nonprofit area agencies. The services are community-based, and it's important to note that New Hampshire is under a corrective action plan for the 3 waivers with the Center for Medicare and Medicaid Services. And what we discovered in our waiver renewal for the DD waiver is that we were in violation of conflict of interest regarding the provision of case management. And essentially CMS frowns upon the agencies delivering case management as well as the services at a systemic level. So we were able to work with CMS to provide that our area agencies can provide service coordination and case management at not at the individual level, but they are able to at the systemic level. And we have been working with the area agencies and a stakeholder group to evolve that corrective action plan. And we have had to request an extension due to COVID to come into full compliance for that plan by July 1, 2023. If you want to learn more about the corrective action plan, it's posted on the DHHS website and it explains this in greater detail. But the state is moving forward with the area agencies and the provider community to come into compliance by July 1, 2023. And this also includes for direct bill and direct pay of services.
Deb, could you send Kevin the link to that?
Absolutely.
Thank you.
So I wanted to talk a little bit about the services that are provided. For the developmental disability waiver, what we do is as somebody exits the school system or is new to the state of New Hampshire, what we do is we work with them to determine what their level of care need is. And then what we do is we arrange services through the area agencies and we deliver the services to them. And HEM 503 defines the eligibility for the developmental disability. And this is the way that things have been working under a single comprehensive DD waiver for years. The next service is acquired brain disorder. And this is for an individual that has a brain injury and would require lifelong supports. And what we do is we provide the supports in the home and the community setting versus in an institutional setting. And HEM 522 defines eligibility, and that's clearly outlined in rule. Then we have what's known as the in-home supports waiver, and these are personal care services for children living at home with their families. And the eligibility for these services are up through the age of 21 and are defined in HEM 524. And the final area that we provide support for is for individuals that require 24 services in a secure setting and are known as 171Bs, and these are defined under HEM 171B. Now, our forensic services are currently delivered through our developmental services designated receiving facility, which is located up in Laconia on the old Laconia State School property. And in this budget cycle, what we are doing is we are transitioning these services from the on-site facility at the Laconia State School. And we are transitioning this to a more community-based approach. And we are working with a vendor right now, a provider right now, to be able to deliver those services effective July 1 under contract. So what you will see as Karen goes through the accounting units is you will see that all 17 positions for this facility have been unfunded and that we have a contract line item for these services moving forward.
Deb, Representative Norton has a question.
Yes,
I
so
thought we had the Laconia School was empty.
Oh, sorry.
Representative Weiler, very good question. The Laconia State School is empty. The property still houses a designated receiving facility that is operated by the Bureau of Developmental Services. That designated receiving facility that just so happens to be on the property of the old Laconia State School, we are phasing out and transitioning those services to a more home and community-based setting, but still meets the secure requirements per 171B. And we are going to be providing those services under a contract versus through the state moving forward.
So how much space are you using and how many people are employed there?
Over the past few years, the census has dwindled. And at this point in time, we are looking at potentially contracting for between 2 to 3 beds moving forward.
Okay, thank you.
I'd also like to advise the members that we are working very closely with the staff at the designated receiving facility that are state employees to ensure that they have opportunities for employment elsewhere within the state, because a lot of their skill sets translate very well to New Hampshire Hospital, to Glencliff, or even to our corrections system moving forward. And we have been partnering with them to determine the best approach on ensuring that they maintain and stay in state service, and they're giving full opportunities to apply for positions. And of course, as we contract with a vendor may very well be interested in picking up some of the staff there as well. So this has very much been a part of our approach to the winding down of this facility.
Representative Norgren.
Thank you very much, Mr. Chair. So I thought the property up there by the Laconia State School is being sold. Is that one of the reasons you're moving, or is it totally just a program planning?
Programmatically, we've seen the census go down, and we see an opportunity to develop this as part of a continuum of care. All right, where this is just another level of care that we want to provide for, and we believe that we can do so by transitioning off of that property.
Right, thank you.
Thank you, Deb. Carry on.
Okay. So I wanted to talk a little bit about the developmental disability, or DD waitlist. And I would like to start by reminding folks that per 171A1A, that the legislature is required to appropriate sufficient funding to meet waitlist costs, and that this is part of statute. And I wanted to explain a little bit about how we manage the developmental disability waitlist, which also is outlined in part of our authority. So who is typically waiting for services? We have students who are exiting the school system, which we refer to as A's. Then we have people who have never accessed services before, but are in need of services. And these are what we refer to as B's. And then we have individuals who currently have services, but require additional services. And these are what we refer to as C's. It's hard to anticipate a B, all right, because these are individuals that may move with a family member into the state, or we have even still to this day have families who have kept their loved one at home with them, and they were concerned about their individual being put in an institution, so they have never come forward looking for supports or services. And if a parent passes away, a sibling or another loved one will contact the state to work with us to get a provision for services. So that describes what a B is. For the C's, these are people who are typically living with their families, and due to a change in circumstance, they require a change in services. So we might have a 79-year-old parent who might have medical complexity and have to themselves go into a nursing facility. And we need to make arrangements to increase the services for the child that they have been living with. And they may look to go into an enhanced family care approach or into a residential group home, for example. And then
Representative Norgren has a question.
Yeah.
Sharon? You're muted.
Sorry, I didn't have another question. My hand was still raised.
Oh, I'm sorry.
I'll try to read that.
All right. And then for C's, we also have people who may not live with their families, but they have changes and they require additional services. So for example, we may have somebody who is on the autism spectrum and is managing to live independently with supports and services, but perhaps they have had some behavioral issues that occur, and that requires an increase in the services. So what we try and do is we work with providing for those services based on the level of care. So I wanted to review where we are this, oops. Oops, I lost my share. Let me bring it back again.
While you bring that back, can you, when we get to the accounts, can you let us know where the wait list appears in the accounts?
Absolutely.
Yep.
Let me just bring this back. Are you able to see that now?
Yes,
Okay.
you're on 41 if you
Yep. Mhm.
don't remember.
Thank you. Here we go. My apologies.
No problem.
Right. So for this biennium, we were able to serve 1,000 individuals in terms of funding them. We have 455 A's and B's that we funded with the original budget appropriation. We have 494 C's that we assisted with the original budget appropriation. And then we funded an additional 51 C's with funds due to vacancy dollars. Oftentimes, what will happen is unfortunately, somebody will pass away or something to that effect. And what we try and do is we utilize those dollars to affect bringing others into services. So right now there are 0 people waiting for services this biennium. And I think it's important to talk a little bit about some of the issues that we've encountered due to COVID. In December and January, we had 46 people who were diagnosed COVID positive in the developmental services system. And that has an impact on the ability to start services and also for us to be very agile in the way that we serve those individuals. So with the COVID crisis, we have had to, we've run into issues with getting workforce. Some families have indicated that they did not want people in their homes serving people. And we've also had the consideration of the Cratchit Mountain closure. During the COVID crisis, Cratchit Mountain determined that they no longer would be providing residential services to individuals. So we had to work very hard and collaboratively with the area agency system to build programs out for 26 people. All right, in addition to being able to support people who we're bringing into services off of the wait list. So beginning in the 3rd quarter of state fiscal year 20, we started to see not as many starts at the level that we typically do. And that can clearly be attributed to the COVID crisis. And I wanted to make sure that everyone was situationally aware that that has impacted the spend rate for our waiver services, our DD waiver services in particular. And I just wanted to make everyone aware of that. So for the acquired brain disorder waiver, we brought in 33 individuals served. And for in-home supports, we've brought on an additional 85 individuals served. And once again, there are 0 people waiting for services. This is a copy of the trending for quite a long period of time. All right, I believe it begins in 09 and now goes to 20. This is something that HHS oversight takes a look at on a quarterly basis. And this is also part of the department's dashboard. And as you can clearly see, as of 12/31/20, there are 0 people waiting for services. So moving forward and building out the budget for the developmental services system and for BDS, We are anticipating that at a minimum of 226 DD individuals will need services. This represents the students known to BDS and the area agencies who are exiting the school system during the fiscal year in 22. And what we do is we take a look at the historic trend on individuals new to the system who may require services. And in SFY 23, we anticipate that a minimum of 198 DD individuals will need services.
Can I ask you a question there? Is that an unusually large number?
No, it is not.
That's sort of normal for a biennium? Do
Yes.
people ever go off services other than when they pass away, obviously?
I think it's important to understand that if you are diagnosed with a developmental disability or an intellectual disability, the assistance you need with daily living either remains the same or can get more complicated as you age. All right. But this is a lifelong support service system. And it is something that we take very seriously here in the state of New Hampshire to ensure that people get the services that they need. And it's a very cost-effective model because the majority of people are served in the home and the community. And
Right. So I was asking in the context of the, right now you said there's a total of 1,000 individuals, correct? Or is that a separate, was that a separate group of people you were talking about back on slide 41?
that includes Cs as well. Those are enhancements as well.
Okay, but nonetheless, I guess my question sort of is that 1,000 or less individuals are there now, and you're talking about adding another 400. I'm just wondering, or roughly that, if that many come in every 2 years, I would expect the number to be much higher, the total number to be much higher.
The A's and B's are generally in the ballpark. They can vary a little bit from year to year. With the C's, it can vary based on where somebody is in terms of needing additional supports and services.
Okay, thanks.
And again, it's a very individualized service system with individualized service plans that are person-centered. So in terms of accomplishments, for BDS, we are in the process right now of working our way through waiver renewals. And we just received approval for the in-home supports waiver renewal with our partner CMS. And we are currently working on submitting the developmental disability waiver for renewal. Just as with BEAS, we are working very proactively with the area agencies and the provider community to provide flexibilities in the way they deliver services. And just as with BEAS, we took a very proactive, high-profile role with our partners at New Hampshire Employment Security to implement the long-term care stabilization program that had the stipends for individuals to continue to work in the field with COVID. And as I've mentioned before, we also have the corrective action plan with CMS that we have made progress on and have received approval for an extension date until July 23. We also have been working on a federal requirement to ensure that we are in compliance with settings requirements, and our compliance for our system here and for the state of New Hampshire for the homes is currently at 98%. And we expect to meet the compliance requirements that are required by Federal Rule 42 CFR 441, which is outlined here. We have also put in a significant amount of effort of working with the educational system and the area agencies to collaborate on transition planning for individuals who are exiting the school system and into adult services. It's very important that those efforts be done collaboratively so that we can do good first projections on needs, all right, for our DD waitlist planning. And more importantly, to ensure that we have an understanding of the individuals that will be exiting and making sure that we have the services clearly planned and outlined and ready to go and have been able to RFP and get the services moving forward. Waitlist management, we continue to work wholeheartedly with our area agency system to continue to fund and start services. But again, the agencies have experienced slower starts due to COVID-19. And that's something that we continue to take a look at very actively with the agency system. And then, of course, we continue to look at system capacity. This past year, we did a lot of work with system capacity builds for the Cratchit Mountain residential program that I mentioned previously. So some of the key challenges for the Bureau of Developmental Services, as I spoke to earlier, is information technology, specifically the ability to effectuate system builds for direct billing, electronic visit verification, and the BDS IT remediation. Another key challenge, which I spoke to previously that speaks to the A&M recommendation, is the need to build capacity for intensive treatment services and make that part of the continuum of care. We continue to work on compliance and operations so that we can come into compliance with our corrective action plan by 23. That's one specific example of a very big lift. But we continue to need to work on ensuring that our waivers are renewed and that we're doing appropriate reporting for financial reporting and quality reporting relative to the waivers. And lastly, I just will speak briefly to the Bureau of Family-Centered Services. In our budget, the Bureau of Family-Centered Services and BDS are both in the same budget and the same listing of accounting units. However, the Bureau of Family-Centered Services works very collaboratively with the Bureau of Developmental Services. And the Bureau of Family-Centered Services is responsible for serving as the state's Title V agency for children and youth with special health care needs. And these are people with, these are children with complex medical conditions. They also provide for family support and the Early Supports and Services program. They are responsible for the contract management and grant oversight for some of the areas that I mentioned previously. The Bureau of Family-Centered Services employs 18 people. And as I pointed out, they were the hardest hit with a 41%, nearly 41% vacancy rate. They are in the process of doing a lot of hiring and onboarding right now. They are responsible for ensuring that we meet all of our federal grant requirements for the funding entities that I mentioned at the very beginning of the presentation with DLTSS. And they are responsible for working and ensuring that we are complying with state, federal statutes and regulations. They also work very closely with the state family support councils and the Council for Youth and Chronic Conditions to get advice as to how the program should be administered and to get input on how we move things forward systemically if there are any systemic issues that need to be addressed. And these are very important partners as we develop programs and administer programs. The Bureau of Family-Centered Services works with community-based agencies. They administer 22 contracts with 14 program sites statewide. And you will see a listing here of the programs that they administer at the bottom here under the community-based agencies. They do child development clinics, which is called Watch Me Grow Coordination. They are responsible for nutrition, feeding, swallowing, and there are a series of other programs that they administer through these contracts with the express purpose of assisting children that have complex medical needs or are being an early intervention to keep them past between the ages of 0 and 3 to enter the school system at the developmentally appropriate level. The BFCS programs, again, they fall under 3 primary buckets, and that's the system of care for children with special health care needs. And you can see here that the eligibility is clearly defined under HEM 520, and these are funded with Title V grants, which were mentioned very early on. They also are responsible for providing family support, and they administer the Partners in Health program, as well as this is covered under HEM 523. And the funding levels for this are through the area agency systems as well as through general state funds. They are also responsible for family-centered early supports and services, which speaks to the Part C early intervention services. The BFCS key accomplishments, again, COVID-19. I cannot express enough the amount of effort that's gone in on the part of the bureaus, working with the community-based providers and organizations to assure that people get the services they need in a safe manner during COVID. And the ability to utilize telehealth and remote services has been extremely important, and it is something that we are looking to implement moving forward. We also have just completed our Title V grant application and compliance, which means that we just completed a 5-year needs assessment, and we did this during the COVID emergency, and we did this poorly staffed during that time period. BFCS has also worked with the managed care organizations to ensure that they understand the types of children that we are supporting, the needs of their families, and so that we get a better cooperation and collaborative approach with the MCOs for supporting these individuals. In terms of key challenges, technology, once again, BFCS uses, in some cases, unsupported data systems to manage case records and for program implementation. We have workforce issues relative to nursing, respite, and pediatric specialty provider shortages that are a challenge for the people we serve and for their families. And again, we had a 41% staff vacancy rate that we are working very hard now to correct. In terms of the unduplicated numbers and for people that we serve and support, I wanted to call your attention to a couple of items on this table here. First of all, under BFCS, you're going to note that in SFY 15, the numbers were 4,310, and now in SFY 20, they're 3,244. There's two contributing factors. Yes.
Representative Norton, go ahead.
Thank you. Thank you. Deb, you're doing a great job. Could you talk a little bit more about the hiring freeze and what the status of that is and where we think we are with it and if it'll end? Or, I mean, 41% is pretty traumatic.
It is terribly traumatic. And the good news is that the hiring freeze is over, and we immediately were prioritized for posting our positions. And in my supervisory with Dee Dunn today, who is the bureau chief, we are well on our way to filling those positions and starting the onboarding process. We've been fortunate that we've been able to fast track this because there is an understanding for the vacancy rate in this bureau.
Guess you're good to go.
So I wanted to talk a little bit about the differential between 15 and 20 in the BFCS line here. In 2015, we determined that we had a duplication in count efforts for our partners in health in our area agencies. And we have been working towards correcting that over a 3-year period. And what happens is as children age out, that correction is made and people are not getting a duplication in services. Another contributing factor to this is that the lack of pediatric specialists for example, for the nutrition and swallowing clinics makes it difficult to fulfill the services at the levels we were before because the children are complex. So that explains why we are looking at lower counts in SFY 20. I'd also like to call your attention to FCESS, which is our early supports and services. In state fiscal year 19, it was 5,038. And in SFY 20, it's 4,595. Our early supports and services programs are delivered in the homes of individuals. And during the COVID crisis, many families did not want individuals in their homes delivering those services. So because of COVID, we saw the census numbers go down. For this budget cycle, I have put in for our FCESS services to come in at the previous amount, the SFY19 amount, because at that point in time, we had been continuously trending upwards slightly. And I do believe that this is an anomaly that is specific to COVID. And I just wanted to call your attention to that. Okay. In terms of workload benchmarks, right now we have our requirements in terms of oversight of the waivers that we have to do what's known as a 372 report, which is a financial report against our waivers. And we need to compare the approved waiver services to the costs realized for services and costs. And we are responsible for doing this on time on a yearly basis. And it's an expectation that this is done 100% on time and accurate. And that is a key benchmark and workload that we work towards. Prior authorization processing. Prior authorizations for emergent services are processed timely at 100%. However, we have been short-staffed in our prior authorization unit for over 3 years. The good news is with the hiring freeze being lifted, we have started the hiring process to be fully staffed again. So we do have some authorizations, SISs and HRSs, which are essentially evaluations or assessments. These are completed after the 45-day requirement due, and some of them are extremely tardy right now. So our objective in terms of prior authorization processing is to approve 100% of prior authorizations within 45 days of receipt and services beginning. And then the other thing we do is we work very hard to maintain the stability of our area agency system, and that we know that we are operating with our area agencies with integrity. So what we do is every 2 years, we do a redesignation of our area agencies, and we review governance, financial management, contractual and regulatory requirements, and client and family satisfaction. This is outlined per RSA 171A as well as in HEM 505. So every 2 years, every year, 2 agencies undergo this review, and the BDS staff works to do this on time and with the consideration that it is due, because it is very, very important. What we would do with the Bureau of Developmental Services and BFCS in terms of incremental and decremented outcomes. If we were given a 5% increase, we would build intensive treatment services capacity in state to drive down the cost per client and enhance positive outcomes for community inclusion. And what we would do as part of that is we would hire up 2 additional staff to help provide oversight for that build. And we would look at starting up residential housing and staffing education and specialty hiring with those dollars. In addition, we would hire 1 staff to provide oversight for the corrective action plan implementation and oversight. If our budget was cut, that would continue to necessitate continued outplacement of some of our people that we serve, which we do not like to send the people that we serve out of state. And we would be unable to potentially serve people off of the developmental disability wait list. And in the end, if we did not serve people off of the DD wait list and we ran a wait list, those individuals would cost more in the long run, because the gains that they had made through the school system would be lost, because they would be at home without the services that they need, and their families would be responsible for caring for them and maintaining them. And with that, I will hand it over to Karen unless there are questions.
Great. Okay. So just doing a time check, Chair. I know you said you wanted to try to wrap up by 2:30. It looks like you still have a quorum. We just have these group of accounting units left. Do we want to try to get through them?
Absolutely, Karen, as long as you're willing.
Oh, yes, that would be great. I think it'd be great to not have to bring the group back for a half an hour tomorrow.
I was actually wondering who you were talking to at first. Then I realized.
I believe you are the acting chair at the moment.
Good point. Thank you for reminding me.
So just going quickly through this 18-19 to 2021, the biggest jump here is the governor's budget in 2021 essentially eliminated the wait list. And as you can see from our current numbers that Deb reviewed, we do not have a wait list. So it did what it was intended to. So jumping right into the accounting units, the first one is 7100, which is developmental services here on page 1132. Chair, you asked to point out when we get to the accounting unit that had the developmental disabilities waitlist. It is included in this accounting unit historically before my time, so at least 3 bienniums ago. Waitlist funds were in a separate class line or a separate accounting unit, and it actually created more problems than it solved. So it is one accounting unit that has all of the potential dollars to serve the developmental disability community.
Okay. So basically between the contracts of program services and the payment to providers is the funding, the 102 and 502. Am I on the right line?
Correct. Correct. The reason 102 is separate is that is 100% general funds. That's for board. We cannot use federal dollars to pay for board. So that's why that's a separate class line. The other thing you'll note is it looks like there's a reduction here from 21 to 22. And in the general fund dollar request for 22, there is. But what is happening is we are anticipating a carry forward from 21 of about $38 million going into 22. And so that $38 million is not reflected in our budget request because it is a carry forward, but it will be part of the total budget available for fiscal year 22 and 23 to carry forward as well. Because this accounting unit in last biennium was designated as a revolving account, so it is non-lapsing and continuously appropriated. Any questions there?
I don't see any.
Okay. The next accounting unit is 5947, which is program support. This is where the staff are for this area, or some of the staff.
So is more staffing anticipated? Is that most of the increase, or maybe?
Nope. I actually think the request from 21 to 22 is actually a decrease, probably because of retirements. Yeah, Deb's nodding her head. So they would have been budgeted at step 1 in 22 because those were vacant positions. And probably
the other thing to keep in mind is that because of the closing of the New Hampshire designated receiving facility, are zeroed out.
That's in a different accounting unit though.
Yeah, but I wanted to clarify because I spoke about that, but I wanted to give everyone a heads up.
Yes.
Don't see any other questions.
Okay. Moving right along then. The next one is 5947, which is, no, that's what I was just doing. I'm sorry. 7016 acquired brain disorder, known as ABD for short. This similarly is anticipated to have a carry forward, which is why this is a reduction here, even from the actual expenses in 2020.
Okay.
You'll see that 22 or 23 rather is more in line because that carry forward will be used in 22.
I don't see any further questions.
Okay, the next one is 7110, which is the Children's IHS waiver.
That appears to be up a bit. Is that, what is that?
I'm sorry, you were.
That appears to be up a little bit. Is that?
Deb, do you want to?
I'm sorry.
Down,
Can you
so
repeat that?
Deb, what
502, the line appears to be up about, oh, I don't know, some between 5.6 million and 7.5 million. Am I reading that right? Or I'm sorry, I'm looking at the wrong, I'm sorry. My columns are colored in all different ways. It's roughly level funded from this year. Is that accurate?
it's down from fiscal year 21, yes.
Okay. Yeah, I was looking at 20 when never mind, keep going.
Okay. The next one is 7014, early intervention. This is not an accounting unit that has an allowed carry forward. It looks like Representative Norgren might have a question.
Go ahead, Sharon.
Yes, thank you. So we're seeing differences between 21 and 22 and 23, and the differences in 22 are quite a few of them related to COVID and the changing of the status of people and serving different people, or what do you think that is?
Are you referring to the developmental disabilities?
Well, I see it under children's waiver, required grade.
So that's because of the carry forward that will be coming forward from 21 into 22. Those 3 accounting units are all continuously appropriated non-lapsing accounts, and we're anticipating funds that will not be spent in 21 that will carry over into 22.
So those funds not spent, were those because of the pandemic or just because they weren't spent?
So I think it was 2 things. It was the pandemic, which Deb spoke a lot about earlier. Also, this was the first biennium where we fully funded the wait list. So I think that it was also level setting what fully funded might require.
Okay, thank you.
Ken, what were the 3? There were 7016. What were the other 2 that were the carry forward?
It's 7100, 716, and 7110.
Thank you.
And we are currently on 714, which is early intervention.
Yep. I think you can go ahead, Karen.
Okay. This accounting unit 7164 is the one that Deb spoke about, the designated receiving facility, which does not have a budget for 22-23 as we anticipate closing that.
So that's the facility up in Laconia?
Correct.
Okay. Because NHH is also a DRF, right?
So the term designated receiving facility is used in a lot of contexts. There are different types of DRFs throughout the state. There are mental health DRFs. This one was specific to the developmental disabilities community.
Okay.
So it's a pretty universal term.
Gotcha. Thank you. I'm learning slowly.
It takes a long time.
I don't see any other questions.
Okay, the next one is 7013, which is family support services.
So this is one of the in-home ones, basically?
Deb, can you speak to this accounting unit and the family support services?
So family support services, we find families eligible for waiver services. And so this could be somebody who is on the ABD, IHS, or DD waiver, but they're also eligible for FSS. So through the 10 area agencies, and the services can include respite, parent-to-parent advocacy, referral help, et cetera, because one of the mainstays of the developmental services system is the fact that the families, in the majority of instances, do the heavy lifting. They provide the room, they provide the board, they provide the clothing and the supports. And what we try and do is help the families continue to do this and give them the support that they need to get respite and take a break and things like that. So this is an adjunct to the waiver services. And in some instances, people may not be getting waiver services, but they do get family support services.
So it's in-home. The family's taking care of someone in-home. That's why they're getting the support.
Yes, but in some instances, they could be in an enhanced family care, and the family continues to get some level of family support because they might be bringing them home on the weekends, for example.
Okay,
What we try and do is we try and take care of the people who provide the natural supports so that we keep them engaged and active in being part of the continuum of care themselves, because they do an awful lot for the people we support.
and I probably shouldn't ask this again because I know I heard it many, many times 2 years ago, but respite again, could you just define that for me?
Sandy, can you define respite, please?
I thank you, Representative, for the question. I'm Sandy Hunt. The definition of respite is a support service that's used to basically relieve the caregiver of providing care to the individual, whether that is usually in their home, and you may have a respite provider come into the caregiver's home, or that individual may go to a respite provider's home, but it's to relieve the caregiver, essentially.
Got it. I've been dealing with this with my in-laws, so yeah. Okay, thank you.
Great, thank you.
Great. The next accounting unit is 7852, which is infant toddler program. This is 100% federal funds.
Love that.
Right? Sometimes I don't love all the compliance that comes with it, I'm not gonna lie.
Now that's on you. I think we're good there, it looks like. I don't see
All
anything.
right. The next one is 7167, Medicaid compliance.
I don't see any hands there either.
Okay. The next one is 7858, which is Social Services Block Grant for DD, SSBG. This is a grant that we have in many places in the department.
And all federal funds, isn't that wonderful?
Yes.
More work for Karen, sorry.
Hey, it's not bad work, it's just sometimes complicated. The next one is 5191, which is Special Medical Services.
Just out of curiosity, what are special medical services? I see it's roughly level funded, a little bit down.
Deb?
All right, what I'm going to do is I'm going to ask Dee Dunn, who is the Bureau Chief, to explain special medical services and the system of care for children with special health care needs.
I haven't seen 562 before as a class.
Mm-hmm.
Hi, thank you. I'm Deirdre Dunn Tierney. I'm the Bureau Chief for the Bureau for Family-Centered Services. And as I mentioned earlier, one of our 3 areas of focus is special medical services for children with special health care needs. And some examples of these services could include healthcare coordination, where a nurse or a social worker actually helps the family to navigate the system of care for children with special needs. They sometimes have multiple appointments, or they need help organizing transportation to get back and forth to specialty appointments. We also offer those clinics that Deb spoke about, early child development clinic, family to family information center, nutrition, feeding, and swallowing, to help children who have difficulties with maintaining nutrition, may have a failure to thrive, they're not growing, or children that are using feeding tubes, to make sure that they're getting evaluations and the services that they need.
Quite a reduction in 22 and 23.
Yeah, so I was just going to say, I don't think it is a reduction from fiscal year 21, but it's bringing it more in line with the actual spending that happened in fiscal year 20.
Does this also carry forward?
It does not.
Thank you.
You're welcome.
Thank you, Deirdre.
Any other questions?
I don't see any others, Karen.
Okay. Sorry, I'm pausing on unemployment compensation because I think that this should have been budgeted department-wide, so I'll check on that and submit a change request on that probably. And that is the end of the accounting units.
Okay. Well, thank you.
You're welcome. We will be back tomorrow with public health.
Okay, sounds good. Looking forward to it.
9:30.
With
They
bated
have
breath.
about 90 accounting units, so
Short
prepare.
one. So I guess we're all done. Can I just adjourn, Kevin, or? I need
Yes,
to-
yes, you can. You're all
It
set.
looks like Representative Norgren has a question though.
Oh, I'm sorry. I thought you were waving goodbye, Representative Norgan. Go ahead.
In a minute. So I would like to know what the scenic photo is that Karen has up on her face there.
So that is no bias, but it's the best lake in New Hampshire. It's Newfound
Newfound.
Lake.
I
It
thought
is-
so.
Yep. That is the ledges, which have lots of history. That part of the road wasn't built, I believe, until the 60s. It's the deepest part of the lake. They've never been able to dive to the bottom of the lake. And anyway, I'll stop now. I could go on for a while about how awesome Newfound Lake is.
I thought I recognized that road.
Yep, that's it.
Thank you.
Keith, tomorrow I'm supposed to be at the Governor's Council Chamber at 8:30, so I'll try to find a place to go online up in the State House or maybe with the LBA at 9:30.
Okay, very good. We'll look for you.
Okay. Bye.